We power hope. We power dreams. We power life. But there's one power we all have. The power to make a difference. The power to vote. Entergy, the power of people.
This edition of Louisiana Public Square is coming to you from the LSU Health Sciences Center in New Orleans.
Good evening and welcome to Louisiana Public Square. I'm Beth Courtney.
And I'm Charles Zewe. Tonight, Public Square looks at health care in Louisiana. We've brought the program to the LSU Health Sciences Center and the Isidore Cohen Jr. Learning Center.
Well, specifically, we're outside the new high-tech human simulation center. The operating room behind us is real, with one exception. The patients are computerized mannequins.
Using the body simulators, medical educators can reproduce a wide variety of medical conditions, ranging from high blood pressure to heart attacks and beyond. This is one of the few training facilities of its kind in the entire United States.
Medical educators say a center like this one will play a major role in improving the education of future physicians. Training new doctors with high-tech tools, however, is only one part of solving problems confronting health care. A report prepared by the LSU Health Sciences Center found that Louisiana residents are poorer, less educated, and unhealthier than the national average, and that Louisiana has the 5th highest rate of uninsured people in the United States. Let's take a look at this report. Louisiana is one of the most beautiful places in America. Its people are among the most interesting, friendly, and unhealthy in the nation, according to John Matessino, president of the Louisiana Hospital Association.
Louisiana ranks at the bottom of many of the lists that you see on health outcomes, and that's primarily a lifestyle issue. We don't have a healthy lifestyle in the state. We have access to health care issues. We have a huge problem with poverty in the state.
In fact, 2003 census data shows Louisiana with the highest poverty rate in the nation.
How are you today?
Dr. Holley Galland, primary care physician with Earl K. Hospital's North Baton Rouge Clinic, explains how it affects her patients.
Change is just plain hard.
Our number one problem is poverty. Poverty is the main cause of mortality and morbidity. Morbidity basically being poor health. If you don't read well, if you haven't been taught good health habits, if you don't have access to transportation, to therapeutic recreation, to resources that people who have funds have access to, then you are going to have a poorer level of health.
Louisiana spends about 80% of what the average state does on health, hospitals, and public welfare. About a third of Louisiana's entire annual budget, nearly $6 billion, goes to the Department of Health and Hospitals. Much of that money funds 10 hospitals and about 350 outpatient clinics spread across Louisiana. This is the charity system, the oldest in the nation and the only statewide healthcare safety net, with the principal mission of providing access to care for the uninsured.
Push down against my hand.
And in a state with one of the highest rates of uninsured citizens, costs are staggering. $510 million spent by Louisiana last year on the care of indigent patients. Senator Don Hines brings his experience as a medical doctor to the debate.
We have about 20%, or about 800,000 people on Medicaid, and another 20%, or another 800,000 people who are uninsured and using our public hospitals for health care.
Budget cutbacks have resulted in very long waits for treatment and appointments, clinic closures, and other reductions in service. Diversion of funds intended for capital improvement has taken a toll in both New Orleans and at Earl K. in Baton Rouge.
I want people to understand care at Earl K. is not substandard care. It's excellent care. The problem is getting in. We don't have the resources.
Well, you go to Earl K. or New Orleans Charity, you might see a good doctor, but you got to have a hard hat to keep the damn ceiling from falling on your head, or stand in line for 3 hours to get to see him. Even the Medicaid patients don't go there.
The loss of Medicaid and Medicare patients is a big blow to the bottom line, because federal dollars from those patients that could help defray the costs of care for the uninsured. The spiral continues downward, extending out to private sector players. Our Lady of the Lake Medical Center CEO Bob Davidge explains.
Private hospitals in Louisiana and really across the country are more and more, if not already, safety net facilities for the community. We provide indigent care, large amounts of indigent care.
The public hospital system is full. It's full. It's at capacity.
John Spain is vice president of the Baton Rouge Area Foundation, which funded a study on the future of the Baton Rouge Charity Hospital.
You go to an emergency room now, and in Baton Rouge, it's fairly common that you may have to wait 2 and 3 hours on certain nights to be seen by a doctor in an emergency room, even if you are a paying customer. That's because they are being overwhelmed by people who are using emergency rooms as their primary care physician instead of having a doctor.
And this is hard on the private emergency rooms. And it's also hard on our state funding because emergency rooms are not an effective way to spend health dollars.
Spending health dollars effectively has never been more important. The state is facing new deficit warnings, and the costs of health care continue to rise. Some health planners are giving a close look at a community-based model for health care delivery, one that turns the nearly 3 centuries-old charity paradigm on its head.
Take a deep breath.
Proponents of community health centers, also known as FQHCs, federally qualified health centers, claim their nonprofit patient-driven approach reduces costs, increases accessibility, and improves quality. There are currently 35 clinic sites in Louisiana. In the end, the inertia of the mammoth charity system will tend to resist radical change, but change will come. The need for teaching, residency, and intern programs will probably keep most of the big hospitals hobbling along. Additional community clinics will help deal with a seemingly unending flood of needy patients. And hopefully, other institutions will foster the improvements in education and economic opportunity that create a truly healthy society.
The big charity system, it dates back to the days of Huey Long in Louisiana. In fact, it is the only state, Louisiana is, in the United States that operates a statewide system of public hospitals and clinics with the primary mission of providing health care to people who are uninsured. Before they arrived here tonight, we asked our participants a series of questions about their attitudes on health care. Our survey, by the way, was conducted by the Riley Center for Public Policy Research at LSU. Using random digit dialing, we recruited participants from the New Orleans area. Our poll indicates, by the way, that they are consistently able to get access to medical care and prescriptions. They are almost evenly split on who they think should have primary responsibility for providing health care in the state to residents, including individuals, employers, state and federal government. Our poll also showed participants believe state government should work to provide insurance for uninsured residents, and they favor promoting general health wellness and preventative programs over helping people with catastrophic health problems such as cancer and other life-threatening illnesses. So let's begin our discussion here with you telling me, if you would, what you think about the state of health care in Louisiana and who should be responsible for taking care of you if you get sick. Who wants to go first? Louise?
Well, I think that's a tough question, but I think it would be nice if the individual could be responsible for their own health needs, but I know in a lot of situations that's not possible. And in that case, I think the state governments have to come up and provide something for the people who aren't able to get health care on their own.
Who else? Aldonia?
Yes, there is a great need for help for those who do not have, health care. And I don't see any other way for it to come.
Have you ever had any health concerns of your own about how your care would be taken care of, or are you okay?
I'm okay.
You're on Medicare?
Yeah.
Didn't mean to deal with your age here, but just thought you might be among the lucky here.
Yes.
Who else?
I am.
In terms of how far the states should go, I mean, the charity hospital system has been around since, as I said, the days of Huey Long. How far should the state go, John?
Well, we mean by state the federal government, which I think plays a large role in this. And Louisiana seems to be a player using federal money to a large degree. the way I see the problem is that we have one class of people towards the top that have good jobs, good insurance. Then you have sort of an underclass that is taken care of with the clinics that were shown in the film, and they have resources. Then there's sort of a middle, which is being dragged at both ends, to my perspective, which can't afford insurance and have a hard time finding a doctor. So I sort of see three different classes to generalize. I think the federal government and the state government are doing a good job of taking care of the underclass. The middle class seems to be sort of in the lurch, and the upper class is probably taking care of itself pretty well with its own resources and the finance system that we have in the United States.
Where do you see problems? What worries you? What concerns you?
Individually? I mean, just from the tape that you just showed, one problem is obviously the emergency rooms. They are crowded if you have money. I don't know, personally, since my mother died in the emergency room, I brought her in there and she bled to death. There were 40 people in the hospital. She had care. No triage system going on, and essentially just too many people sitting there. It seems to me that one particular problem is if the triage nurse would say, we're not going to see you for 6 hours, make a clinic appointment or do something else, then the emergency rooms would clean up a little bit. So that's something which was brought out, which I think we could handle real quickly. You tell people who's going to see a doctor and who's not going to see a doctor, and there may be some federal requirement that all people see a doctor every time they come in. And if that is the case, I tell them you might be 8 hours. But it was rather disappointing that that's the system that worked. And again, you go to charity. I mean, if I was an automobile wreck, I would want to go to large charity, a big charity, whatever they call it now, because that's where all the good doctors are with all the good equipment. They bring you to some other hospital, you're in trouble. So, but I mean, there are problems all over the system.
But I saw a number of you shaking your heads. Ivanka, I think you were shaking your head talking about when Beth Courtney mentioned about the delays in the background report. Tell me about that.
Well, I think that healthcare as a whole in the state really needs to be addressed, and I think that we should see some changes in the upcoming year. But in response to the delays and accessing healthcare, whether it is if you go through the emergency room, if you will, or if you're trying to do like something routine like a doctor's visit, it could take you a year or so just to get a dentist visit or a visit with a doctor. So I think accessibility is really the demand for it, and responding to the population is something that really needs to be addressed and in the agenda, and I think it needs to be looked at, accessibility and acquiring those services, so yes.
Quentin, how about you?
Well, I kind of agree with what she said, and I feel as though it's really the government responsibility to take care of those that ain't able to provide health care for themselves, because we have, what, a $6 trillion a year deficit, and they can spend billions of dollars to make all these mass destruction weapons, but yet we got people that's sitting here dying day in and day out trying to get help for themselves, So I feel as though it's on the government to provide that for those people.
I'm not trying to personally probe what your situation is, but do you worry about your health care, or are you okay?
Yes, I worry about my health care, but I have insurance, so basically I'm okay.
Clara?
What I see is that you don't have enough branches. I live on the West Bank, and I run a community center. And if we had a branch of charity, we have the private hospitals, but so many people have so much confidence in charity hospital that if we could get some branches on the west side of the river whereby people can go to these different little stations. My aunt was 86 years old. She was very ill. We took her to one hospital, and we sat there about 4 hours. When they did treat her, they sent us to the other hospital because they say they didn't have the time, too many people were there. We stayed there, and when we ended up after 8 to 10 hours at Charity Hospital that really served my aunt. So
did you feel the system let you down, let your aunt down?
They did. I think if we had a nearby station of Charity Hospital, I have a lot of respect for Charity.
I want to come back to that and say that there's been some talk about breaking up the Charity Hospital, into, as you may know, into a system of smaller clinics around the state. Shamika, how about you?
Well, I'm in the Baton Rouge area, and I've been affiliated with both the Our Lady of the Lake Summer Hospital, as well as they have Baton Rouge General. And my biggest concern is about the quality of services. You may wait 2 to 4 hours to actually see a physician, but once you're in there, his visit is maybe 10 minutes. And are you really, for the time that you put in, for the money that it costs, healthcare providers or whatever the case may be, it's like the quality of service is not, it's not adding up. It's like I'm putting out all this money for emergency room visit, but I'm not getting the services that I actually am due, you know, and it's a poor situation. It's very bad.
In terms of, I think Antoinette mentioned it, about preventative care, and John also mentioned about having people, you know, getting in more into wellness programs. Nicole, is that, you think there's very much value in that?
In the wellness program?
Yes.
Yeah, definitely. Wellness programs will be good, especially when they branch out for individuals to go to these different clinics and get the hair care that they need. I really do think the healthcare in Louisiana really does need to improve.
How so?
I think the middleman, it's not the individuals who are getting the care that they need. You know, the individuals that are wealthy are able to afford the health insurance, and those that's at the lower class can apply for, you know, state benefits to get good medical care. However, your working class, who, you know, who's working every day, but don't meet that income level, you know, to qualify, but cannot afford, you know, health care. Where does that leave those individuals?
Well, it's happening more and more according to statistics. More and more people are depending on the state, like 1.7 million, I believe is the number. But Beverly, how about you? We haven't heard from you yet.
I'd like to go back to your earlier question about whose responsibility is health care. It's a personal and family responsibility for all of us, because ultimately we know our bodies better than anyone, and it's up to us to go to the doctor and to seek out medical help when we need it. But I find that the biggest obstacle for most people, whether they work or do not work, is access to quality health care at a reasonable price. Even if you work, sometimes the cost is prohibitive, even with insurance. And for folks who don't have any insurance at all, often getting to a place where they can access care is a problem. So we really need to look at ways to get health care close to where people are, and to collaborate so that we provide a quality of health care regardless of whether that person has money or money.
State spending, I think, around $500 million a year on health care. But before we get into that, does everybody here have insurance, health insurance?
Yes.
You're all looking at me like maybe not. You don't have to tell me. I'm not trying to put you on the spot here. Uninsured people are a big problem in the state. How far do you think the state should go in coming up with some sort of catastrophic care?
Well, I'm glad, it's interesting that you brought that up, because as an employer as well as a user of health care in the state of Louisiana, I made a goal last year to offer, to get aggressive and offer a health care program for about 150 of the employees that I have on board. And just looking and pricing out for this group of individuals in response to their income level, and seeing, you know, what is available to them. Speaking about a catastrophic types of care, it's very expensive, and we had to get very creative and negotiate to try to find, just for us to purchase a package for individuals that are employed by us, so that these individuals have more options than just the charity system and the public facilities. So I think that one of the problems that we're finding is that if the government is going to participate, they need to also participate with the insurance companies as well, for those individuals that's not, even the companies that's not very, don't have a huge budget to take care of that type of.
You're a small business owner.
Yes.
And how much did your insurance premiums go up from last year to this year?
It went up about $35 to $45.
Percent-wise would be what? About how much?
I would say about 15 to 25%.
And did some of your employees cut back on their coverage as a result?
Exactly. My manager just had a discussion with me, my administration manager, saying that I'm getting calls from staff and employees wanting to pull out, because this was our enrollment period, because the rates went up. So I made a decision to kick in additional money and to transfer some money out of the budget, just so that, you know, we have to ensure that individuals have a peace of mind when they're ill. That's the most important thing. And in doing that, that's what we're trying to do as an employer.
John?
My view on this is that, first off, people in America have like high expectations where they want things without having to pay anything. My experience when I had some circumstances where to get just a catastrophic policy, are pretty cheap. Where if you go with like a $5,000 deductible with no benefits and you'll pay $5,000 out of your pocket for the year, you can get that for less than $200 a month. If the uninsured people were getting these catastrophic policies, and maybe they were getting some state assistance in paying that premium, which would be, and I'm pulling this out the air, pretty much about $200 a month. You go into a hospital with that policy, and you run up a big bill, the hospital is going to be pleased with you because the doctors don't like to sue. And if everybody had sort of like a basic automobile policy, it would make a big difference for the state not having to pay for these other expenses that aren't being met. So what I guess I'm saying, it'd be sort of like a minimum uninsured policy basis, that if all the poor people would get a catastrophic policy, most of the costs would then be paid to the hospital and they could eat.
When you say poor people get a policy, you
I'm
mean
talking about
the
the middle
state?
class, the middle class. If the middle class would start getting catastrophic policies at a low premium with a high deductible, you go into Mercy Hospital and you have a $5,000 deductible, you run up a $100,000 bill, Mercy or Baptist or whatever hospitals are now would be pleased as punch just to lose $5,000 on the deal. They're not even going to come after you. And so what I'm saying is that the state would help the middle class who doesn't have insurance get catastrophic policies by giving them $100 a month. I think our health insurance problem would almost be gone.
Everybody agree with that? Anybody disagree with that?
It's hard to do that in a 90-second sound.
What he's saying, because I'm in the health insurance, life insurance industry, and people just don't want to spend their funds. They want the government to do everything for them. And unfortunately, the people here who are on this panel are absorbing those costs and the high cost of health care for us. My suggestion would be that everybody pay at least something into the system. The people who are on government assistance, we could strategically set medical clinics around the area so that they could go to those places for wellness checkups, which would probably alleviate a lot of the cost for catastrophic illnesses.
Quentin's shaking his head. I saw him, he was looking at you, shaking his head. What's wrong with that idea, Quentin?
Nothing basically wrong. I kind of agree with what she was saying. She got a good point.
She got a good point?
Yeah,
You're shaking your head for another reason. In terms of who's going to, there are a lot of people in the state, though, who can't afford even a minimal premium. And there are a lot of hospitals, private hospitals, because private hospitals are being confronted with patients who show up in emergency rooms for care, and that's uncompensated treatment that is being dispensed by the hospital. So what do you do about people who just can't afford even the most basic premium? Aldoni, what do you think?
Yeah, sir. I don't know. I really don't know. But the money has to come from somewhere. And I'm thinking the place that it probably will come from is the government.
And you think that's the way it should be?
Well, I'm thinking that's the reality of it.
Miss Business Owner here doesn't think so.
I think we need to be conscientious about education, period. And if we are going to try to change some things, if I'm telling a person who is a $6 an hour to $7 an hour employee working that wage, and we're telling them that you're paying insurance premiums, well, they're of the mindset that I'm paying my insurance, I'm paying into this system, may not ever get that ill. But then if they do get ill 5 years later, and then they're asked to pay $5,000, that is very relative. So to that person, that may be extremely expensive, and not that they would not want to pay. I don't think people genuinely just don't want to pay for something, but it has to be something obtainable, something within their reach. If you tell them that, okay, you're going to be hospitalized, but you need this bill for the 30 days, 60 days is about $500. That is something more obtainable that they can reach, as opposed to something as large as like $5,000, because then they feel as though that, you know, they'll never ever be able to accomplish that.
Well, let's talk about another hard question, but we're running out of time for this segment. Lifestyle. I mean, between gumbo and po' boys and jambalaya and etouffees. I mean, we eat well in this state, and we pay for it, right?
Yes.
So what would you do about that, Beverly? I didn't pick on you intentionally. I mean,
Well,
nobody here
mean,
has that problem,
you know,
right?
Education is the key, and it's high time we got our young people involved in helping us change the lifestyle of the adults in this state. They've done a good job of helping us cut down on smoking in the nation, and I think we can really get them involved. We really don't do a good job at the workplace, at our public schools, at our universities, of really pushing home the importance of wellness and preventative care, and we really need to do a better job.
Well, here's a young man right here. He's skinny, so he doesn't have any weight problems, right, Courtney?
Well, I'm a vegetarian, so.
Oh, there you go. Now what? Now in this state,
And still enjoy our gumbo.
right? How do you get along in this state being a vegetarian?
I get by very well. You know, I'm healthy. I exercise. You know, so.
And you never have a bowl of gumbo? Never anything like that?
Nothing with me.
Really? That's unusual. Antoinette, how about you? Is it a matter of education?
I think it's a combination of all those things: education, diets, accessible to health care, access to health care, preventative maintenance, preventative health care, all those things.
John, Clara, you agree?
I think it's what she said plus your lifestyle. I'm 72 years old, and I was ill about 35 years ago, and I can't eat certain things. So I don't eat them because the doctor told me if I eat them, what would happen to me. So it's the educational part of it.
But we certainly see a lot of people on the street every day, in the shopping malls every day, and you know what I'm saying, John?
Yeah, well, obviously, the obesity level is sort of obvious if you walk into a mall or walk anywhere. How are you going to get people to change their behavior? Maybe we're missing what we had in the past with shunning, where lifestyle, I'm not saying put them out of society, out of the clan or something, but before, people would be more critical of other people's choices. Now there's very little incentive for anybody to criticize anybody for doing anything. So maybe society has to become a little bit more critical about people who have lifestyles that aren't appropriate. On the other hand, if people weren't smoking, they'd be living longer and the Social Security system would go bankrupt 10 years sooner, possibly. So there may be another side to this coin that if we live too long with the problems with health care, it may not be the solution that we're actually looking for.
And those problems may take care of themselves, is what you're saying.
Yeah, well, yeah, with people dying sooner, because we're all going to get, whether we get sick at 96 and then linger, or we get sick at 76 and linger, that's 20 extra years of government expense. So it might be better to linger earlier rather than later, if we're actually going to look at it just on a cost actuarial basis.
That's a Hobson's choice if I ever heard one, Clara.
You also eat according to your budget. And the budget that many people have are those fatty foods. The hamburgers are 99 cents. And in order for me to get a good meal at least once during the day, I'm going to get a hamburger. And what happened to me? I might gain 10 pounds each day. It is according to your budget.
That's all the time we have for this segment. Thank you very much. We're going to wrap up the first part of our Public Square discussion. We'll take a quick break, and when we come back, people on the front lines of dealing with health care in Louisiana will join us to take questions from our participants here tonight. You too, by the way, can become part of Public Square by taking our online survey on health care at lpb.org. We'll be right back. As we continue on Public Square now from the LSU Health Sciences Center in New Orleans, we're joined by Dr. Fred Cerise, Director of Louisiana's Department of Health and Hospitals, and Dr. Gary Wiltz, a physician with the Teche Action Clinic in Franklin, Louisiana Community Health Center. Thank you, gentlemen, for joining us. And who wants the first question? Who wants to ask about health care? John?
I have a question for my own interest, trying to learn something since I'm here. My understanding is that private medical schools can make money training students. In fact, there are even some moves to start additional medical schools in the United States of a private nature. We have a great facility LSU runs in New Orleans and also I think one in Shreveport. It seems to me that if Tulane can make money on students, why couldn't we have more students in this facility, whether you had a choice of going to the Caribbean to learn to be a doctor, or come to New Orleans and maybe work a night shift because of facilities. It seems to me the state could make some money by training private doctors for kids that can't get into medical schools. I mean, is there a problem with the AMA allowing more doctors to be trained? But I mean, we've got the infrastructure, we've got the professors, we've got everything we need. All we have to do is get the rich students, bring them to New Orleans. It might help New Orleans' economy. Some of them would stay here. So I don't know if that's...
I can tell you, just from my own personal experience, I went to Tulane Med School and did my residency there, and was not a rich student. I had actually a scholarship with the National Service Corps. That's how I wound up in the rural community that I was in. But there is some debate and some talk. As a matter of fact, there's a guy in Baton Rouge that's looking to try to start a medical school there.
A private school?
Yes, in addition to, that would actually help to solve this problem that we have. And I think the root question is, though, is it's not a shortage of physicians. It's never been that. It's a maldistribution. And I can tell you as a native New Orleanian, it's difficult to get people from New Orleans or from major cities to go out to these small rural communities. So that's where we have the biggest problem. One way to solve part of the problem, we were talking about this earlier, was to have more mid-level providers. Those are nurse practitioners and physician assistants. And they play a tremendous part of the team to help try to solve that problem.
What about that, Dr. Cerise?
Well, I don't, I'm not familiar with the books at LSU, but I don't think that I doubt that Tulane makes a lot of money off of the med school, and I know that it's an expense to the state to do the training. So I'm not sure the financial piece of actually making money off a school would be tough to do because there's so much expense associated with the
Well, I'm
with
just
the schools.
assuming that they would be able to do like night courses or something because you've already got the infrastructure. And then again, my premise was rather than going to Grenada to learn something, I'd rather be working nights in New Orleans. So
Well, so on there's so much clinical training that goes into it that it really is difficult to get quality experiences for those clinical years, and I'm afraid that could very easily get diluted, don't you think,
Well,
Gary?
let me try to cut to the quick, though, and then maybe get to the heart of some of what you're saying, and it certainly is an issue in the state. What should be the role of the teaching hospitals in the state, in New Orleans, at LSU, Tulane, and up in Shreveport? Should they be concentrating on training doctors or in treating patients? Because certainly the doctors at LSU and Tulane here comprise the backbone of the healthcare delivery system. Would you agree?
Right. And I think you indicated the role is a dual role, and they feed off of each other well in those areas where you've got the good training programs. And so the hospital system provides a milieu in which the training can occur, and so those students and residents get an opportunity to get their training done, and in exchange for that, they get a training opportunity, and so they get to further their training. So they feed off of each other.
The original intent of LSU and Shreveport was actually to educate physicians that would go to more rural communities. That was the original call. But I think getting back to the economic question you asked, and I think this has been a topic here in New Orleans, I think they're close to, 10,000 healthcare jobs that are going unfilled. So, and we're part of the team in the healthcare delivery system. There's a tremendous shortage of nursing out there, nurse practitioners and PAs, as I mentioned earlier. So there's a lot of work that I think we can do in the state to help try to solve part of this problem.
So, Ivanka, from what you've heard from Dr. Cerise, does that satisfy you? Is that something that planning was talking about, something you'd like, would do?
Yes, we need to look into it to see the success rate. As he mentioned, it hasn't been successful in Oregon, I think Wisconsin as well. So we need to just see, how it's going to relate to the community, and I think that goes back to education, educating them on this is the benefit of it, and we had to expend a lot to educate our staff, our employees. This is what the benefit is for you.
Gary, you wanted to add something.
Well, speaking of education and enlightenment, let me tell you about a proven track record, and that's community health centers. We've been around for over 30 years now, and it addresses just the issue that you mentioned. We have patients that we treat. It's a means-tested sort of system where you bring proof of income, and the rate that you described, some of the employees' hourly rate per pay, they would actually be eligible for comprehensive primary and preventive care in a community setting for a copay based on their income. And the average cost in someone, say a single person making $19,000 a year, they would pay $10 per copay for a complete visit, or 10% of the total charges that they would experience.
What do you mean by best kept secret?
Well, we've been around and we've been trying to be a part of the solution to this healthcare dilemma for the last 35, 40 years now. Our center in Franklin's been around we'll be celebrating our 30th year. We've presented this to the legislature. We've actually tried to do this for a number of years to get this out, that we've been around in small rural communities mostly, but there's some here actually in New Orleans also. But the way that they work is, as I said, proof of income. I can tell you I'm an internist. Everyone on our staff is board certified. We're Joint Commission accredited. We affiliation with the actually Tulane Preventive Medicine Program. We offer in-house pharmacy services at a discount. We also offer dental program, mental health, the whole array of preventive and comprehensive primary care.
Clara had a question.
That's when I was saying that Charity Hospital is an excellent hospital, and I've been living here all my life, and I have a lot of respect for the work that they have done and still doing. but we don't have enough of those types of centers. We have one in River Ridge and one in Avondale. But when you look at the metropolitan area, it's such a broad area. And a lot of people, I feel, believe, are going to the great beyond because they're not able to get the services that they need.
Well, I think, Charles, you alluded to that earlier about Huey Long, and it was a great idea. The whole concept, I think, of charity. Louisiana should be proud. We were the only state that had the compassion to name it what it was, Charity Hospital.
That's right.
But in today's society, if you fast forward, that is not meeting the needs of all the folks. I was born at Big Charity here in New Orleans, and I trained at Charity, and I can tell you, we used to see people from 50, 100 miles who would come to see us. They would wait for long periods of time, and the quality of the care they received was excellent. That's at Earl K. Long, and I did some of my training at Huey Long in Pineville. The problem is that they were passing all along the way venues that they could have been treated in their local communities. And then once we treated them in our high-tech centers, and you can do all these diagnostic testing, at the end of the visit, when you sat down to write those prescriptions that they couldn't get filled, you were spinning your wheels.
Well, what about the...
Well, I think Gary, he makes a good point. In reality, there's two parts to the coverage issue. One is you can try to insure people, and as a state, we've tried to do that through the Medicaid program and the CHIP program, and for pregnant moms and kids, we've done a good job. But we still have 830,000 uninsured, and for those people, we need access points of care so that they don't have to go to the emergency rooms to get their care. And so the community health centers provide those access points. The public hospital outpatient clinics provide those access points. Rural health clinics do that as well, our parish health units. And so we've got to all work together because those are all pieces of the solution. And it's so dependent. I mean, Gary has a model program at Teche, and I think that's where the answers are going to be in local communities, good people doing with good abilities, taking the responsibility and providing that service.
Louise, you buy all this?
Well, I have a question. How is your clinic being funded?
Well, it's the CPA in you would appreciate this. It's a mixed portfolio, if you will. The patients, well, no, this is how we operate, and I can give you the breakdown, the pie chart. About 28% are Medicare, which is the most vulnerable population. That population, because they enjoy the benefit of our in-house pharmacy, because they get almost all their medications free. And those are the ones that need medications the most. But we also have 22% Medicaid, about 10% private insurance, and the rest are self-pay. But the self-pay, those $10, $20 co-payments generate a revenue stream for us of about $400,000. So if you look at the total program, the rest of the care, we get a grant from the federal government to help subsidize the uninsured care.
Now, who built your...
Go ahead.
Yeah.
Who built your center?
We've been around...
That's where the problem is. I think a lot of people can get the different materials of medicine and all once the building is built.
Well, we've actually, and Fred and I have had this conversation, and we've had this conversation with the state for a number of years. And one idea that was floated, and I think Senator Breaux mentioned this in the healthcare reform panel, was that we have some of the bricks and mortar already in place in Louisiana. Every parish has a public health unit. So there are some bricks and mortars out there, especially in these rural communities. And in our center at Franklin, we actually are housed in one of our buildings. This is what used to be the public health unit that was giving immunizations and part of the care. Now we're doing comprehensive care. That's it.
Nicole, how about you? Go ahead, Shamika. You had a...
Well, actually, that's what I was referring to at first, but you gave the title to it, community health centers. Because when my concern was quality of services. And you would have these same physicians that would come in and they would have this particular day and they provide this particular service, whether it was the dentist or optometrist or whomever it was, and whatever service you might have not needed at that time. And when you were talking about the amount of money that they have to pay or the cost, when I would go in, or me or whomever would go in, it's a minimal payment, but you still receive the same quality of services. I guess I didn't have a particular question. It was just wanting to get some comments or feedback on how do you think that, how effective did you feel that was?
No, I mean, that's the whole idea, is to have that service available for working poor people. That's the bulk. The big fallacy in this country, in this state, is that the working poor are, they're lazy, or they don't. These are some of the hardest working people that we see. We see them every day, but they cannot afford those premiums. And Fred alluded to a program that we're actually doing, a model, the 3-share program, where the employee, you can afford maybe $20 a month co-payment for them to go to a center, but you can't afford maybe $200 a month premium. So, I mean, we're looking to try to put that combination together to help try to solve some of the problems.
Quentin, did you have a question?
Yeah, I want to know, how do y'all feel about the topic of the healthcare situation that we have in Louisiana, and the overriding of charity and people who really hurt not being able to see the doctors and get the quality help that they need? And I want to know y'all input on that situation, how y'all feel about it.
John said his mother, bled to death in the hospital,
Yeah.
John?
Yeah.
Well,
And-
she was 96. So had they got her into surgery, the outcome probably would have been too beneficial for her anyway. So I really wasn't that upset.
But
when
she
it
still
happened.
waited, and I
But
think
it's
that's
still,
what-
it could have been a
right,
healthy person that would have done the same thing. There were 40 people in the emergency room at a private hospital, and the triage nurse didn't.
Well, what about that issue of people just not being able to get the services, right, Quentin? That's what you're saying.
Well, I think, and this was not at one of the public hospitals.
No, this is a private hospital.
Yeah, and see what happens is the problem of uninsured is a problem for everybody. If you don't have the adequate access points in the clinics outside of the hospitals, what ends up happening is people clog up the emergency rooms of hospitals, and then everybody waits because there's no, you don't triage by payment source. And so if we don't have the adequate entry points in the community clinics that patients can access, then the hospitals do get overcrowded.
I agree. When you tweak something, something else has to give. When the cutbacks occurred in the charity system, those patients are going to seek care where they can. And a lot of them went to the private sector, and that impacted the bottom line cost that you alluded to.
When you talked about the Oregon system where they had this plan and nobody bought into it, I think the problem is, just my gastronomical impression, is we have a very, very good safety net in America. I mean, people can say what they want, but compared to other countries, even if you don't have insurance, you get treated. You go into a hospital, you get treated. No one dies, very often anyway, because they can't find a doctor. So why should these people take any money out of their pocket if they're already getting services, keeping all of their money in the pocket? So I think what we've got to do is, like you said, getting a little bit of copay from everybody that comes in, getting a small amount of insurance premiums from people that aren't insured would make a big difference in a system that's functioning pretty well. But I think we have to come in with some sort of hammer on people that if they don't contribute something, they don't get the free service. But how do we do that?
A hammer? A hammer approach?
A hammer, well...
You mean a reflex hammer like we're testing?
A little rubber hammer.
That kind of hammer.
You got to do some editing for me.
I think you make a good point, and that is we can expect individuals, and you all said it, I think we can expect individuals to pay what they can reasonably contribute to the health care. You know, this past year in the public hospital system, the legislature, the year before this one, passed a law that said if people make over 200% of the federal poverty level, so double what Gary was talking about, I think, then they are responsible for their bill in the hospital. And you can, for routine stuff, you can deny care. Not in the emergency room, but if they show up at clinic and they haven't paid their copay, then you don't have to provide care. For those people over 200% of poverty. So now, can you go down to 100%? You probably could and expect some payment from those people, some modest amount that everybody can contribute to. I think it's a good idea.
Nicole, Antoinette, Aldonia.
Is there, are you guys putting anything in place to put these community care centers where they're more accessible for people?
Yes.
And I really like what's going on at your clinic. I worked at a clinic like that in Georgia, and we saw people with as little as 50 cents. It depended on your income. So I think that should be put in place across the board. And another thing I think, too, that if someone is going to be on public assistance, and believe me, I'm all for helping poor people, but in order to cut back some of the costs that we're spending on catastrophic illnesses, maybe we should make it sort of mandatory that they have 2 wellness checkups per year. Because normally within a 6-month period, you can catch whatever it is that may be occurring.
Well, that's built into the model, the prevention. But, you know, I think it's going back to something you all alluded to earlier. We have patients' bills of rights that are posted, but there's also patient's responsibility.
Right.
And that's where you get into the issue of lifestyle prevention. And you just have to have a frank conversation with the people of the state of Louisiana about the lifestyle. And we have that every day in our office, you know, with someone that's smoking. I mean, if you look at the public health issues associated with smoking, diet, inactivity, and the things that people can take some responsibility and change, as well as means testing through proof of income, that they contribute to the process.
I would assume that means testing is very, very expensive. I mean,
No, you bring your proof of income. It could be your W-2 form, your check stub.
If they don't show up with it.
You have to, in order to be
That's a
eligible for the
must.
discounted programs that I'm
You
talking
have
about, you
to.
have to have that proof of
That's
income.
right.
Nicole?
Yeah, I had a question. I wanted to know, what is the state doing about getting awareness out there about these community health centers? Because the only one that I know of is Planned Parenthood. You know, I don't know of any other centers out here in the metropolitan area for, you know, routine medical visits for, you know, anyone, males, females, or anyone.
Well,
And I run into that a lot with family. You know, a lot of my family members don't have insurance. They're working people, can't afford insurance, but don't meet the guidelines for, you know, public assistance. And they're skeptical about going to the doctor because a lot of times they can't, you know, pay that doctor visit. You know, $160 it may be just to visit the doctor. But I think if the community knew about, you know, these centers out here, you know, you will really grasp a lot
Actually,
of individuals.
DHH has embraced the whole concept, and we're looking at doing a 5-year statewide strategic plan to double the number of centers. And I can tell you on the national level, President Bush actually put $1 billion into doubling the number of these centers nationwide. And we've had conversations, and we're trying to get the word out. There's been an assessment done in every parish to try to ascertain the needs in the
We
short
have
area.
2 in Jefferson Parish, one in River Ridge and one in Avondale.
But what's the
They-
practical impact of that, though? I mean, Dr. Cerise, I mean, you're the fellow from, unless I'm mistaken, you're the person charged with having the conversation with Louisiana, right? I mean,
Well, as
about all of this.
as I said, the access points are numerous, but the community health centers, we are, as Gary said, we're in this effort to increase the number of them. The limiting factor there are a couple, but the major one is you've got to submit an acceptable application to the federal government, and they have to grant you a site. And so in Louisiana, this past round, we had one successful application. And so there is that major hurdle to overcome. And so in the meantime, while that's growing, we need to do a better job. There are other things that we're trying to do, trying to take some of the money that's available for uninsured in the public system and in the private system, and take those dollars that generally are attached to hospitals for the care of uninsured and make those available to communities so that communities can then step up and develop access points and use those federal dollars for that.
Dr. Sharif, I have a question in response. It's similar, but it's going to take us to like another topic. The state option plan and the transition from one of your waiver programs to another waiver program is in response to the Bartholomew lawsuit. And I know a lot of that happened under the previous administration before you came. What is the intent of the department? I think the community centers is going to be wonderful in responding to more individuals being on this community-based program. But what other plans do you guys have for more consumers in the community now, because of now, so to speak, the floodgates are going to be open or have been open to provide more services to individuals with disabilities to live independently?
Were you talking about the elderly
Yes, the elderly
services,
waiver,
the Medicaid
the
state plan?
transition, yes.
And what she's referring to is the Medicaid program now has a program whereby people who meet nursing home level of need can be taken care of in their homes, and they can choose that option, and the state will pay for, based on need, certain hours of services. And so the state is in the process. The demand for that program was greater than anticipated. And so the contractor that the state used is gearing up to speed on that, and I think you'll probably, if you haven't seen it, you're seeing some of those patients right now.
We're rapidly running out of time, and we have not heard from Aldonia.
Right. Busy listening. It's a very interesting conversation, and I'm saying, okay, that would be good, and that would be good. Do we really get off the ball and get some of this really rolling so that we
Who's
can
going to
see?
do it?
Yeah.
Well,
And when?
Well, it's ironic we're sitting at a table because, as I'm sure all of you are aware, the governor's convened the healthcare reform panel, and I'm proud to say that I'm on that committee, and Dr. Cerise is chairing that committee. And I think for the first time in a long time in this state, we have people at that table that, just like the people at this table, hold the solution to this problem.
But Aldonia wants to know, where does the talk stop? Tell me if I'm quoting you correctly.
Right.
Where does the talk stop and the action begin?
Well, I'll comment on that, because this is going to be the kind of problem. It's complicated and it's widespread, and we're going to chip away at it. And we talked about prescription drugs. Gary's got a program. that makes prescription drugs available for cheaper than you can go to Canada and get drugs. And so we are trying to make sure that all eligible entities participate in that program. So for uninsured individuals, you can access drugs at a cheap cost. For the community health centers and the access points in the community, we are expanding those points. But it's going to be the kind of thing where we're going to chip away. We're going to have small successes, and cumulatively we'll make an impact here.
And believe it or not, that's all the time we have, Clara, and everybody else. And we want to thank everybody for participating, all of you this evening, especially Dr. Cerise, Dr. Wiltz, and we'll be back with a few final comments right after this.
After our discussion, we again surveyed the participants on healthcare issues and compared their responses with earlier results. And we found some very interesting things, Charlie. We talked to them about access to healthcare and the quality of the healthcare. And upon thinking there was a decided shift, they now think that the care is better, but perhaps the access is worse.
They're just tired of waiting for so long.
Absolutely.
One thing we talked about that after the show was the fact that maybe it's time to take a different look at the charity hospital system. As you, many of our viewers know, maintaining the charity hospital healthcare delivery system has been almost sacrosanct politically. But now, the people who take part in our lives, and admittedly it's a small sample, but they think that supplying healthcare insurance to people in Louisiana is more important than maintaining the charity hospital system.
And we also know that they are interested in community health centers, and so that is a shift. But as in previous audiences, they also have decided to more confident in decision makers and government when they finally have a chance to express their opinions on public square.
One final thing, there was a decided view among our participants that maybe it's time to push away that gumbo ball and that play debate too fast, and for the state to concentrate on wellness programs, preventive care programs. Perhaps that's all. We'll see.
Are you getting up the gumbo? No. Well, right from the Louisiana Public Square for this month, you too can become a part of Public Square by taking our survey on healthcare at lpb.org.
In October, Public Square will originate again from Baton Rouge as we turn our attention to national and international issues with the presidential campaign coming down to its final days.
Well, until next month, for Charles Zewe and Louisiana Public Broadcasting, I'm Beth Courtney. Good evening.
A home video of this program is available. For more information, call 1-800-973-7246 or write to the address on your screen.
We power hope. We power dreams. We power life. But there's one power we all have, the power to make a difference, the power to vote. Entergy, the power of people.